Bismillahirrahmanirrahim. Rabbi zidni ilma. You can't go back and change the beginning, but you can start where you are and change the ending. Assalamu alaikum. My name is Dr. Sadia Rafiq, and today my topic of presentation is cholera. The learning outlines include introduction of cholera, epidemiological triad, chain of transmission, clinical stages, levels of preventions, and recent advances. Learning outcome. At the end of this presentation, you should be able to describe the epidemiological triad and the prevention aspects of this infection, explain the factors that contribute to its spread, and knowledge of the recent advances. History. 7 cholera pandemics have occurred in the past 200 years, with the first pandemic originating in India in 1817. Additionally, there have been many documented cholera outbreaks. In 1879 to 1883, major scientific breakthroughs towards the treatment of cholera developed. The first immunization by Pasteur, the development of the first cholera vaccine, and identification of the bacterium Vibrio cholera by Filippo Pacini and Robert Koch. After a long hiatus, a seventh cholera pandemic spread in 1961. The pandemic subsided in 1970s but continued on a smaller scale. Outbreaks occurred across the developing world to the current day. Epidemics occurred afterwards, civil unrest or natural disasters when water and food supplies become contaminated with Vibrio cholerae, and also due to crowded living conditions and poor sanitation. Introduction. Cholera is an acute diarrheal disease caused by Vibrio cholera 01, classical or EI tor, commonly due to EI tor biotype. Cases ranges from symptomless to severe infections. Majority of infections are mild or asymptomatic. Typical cases are characterized by the sudden onset of profuse, effortless, watery diarrhea, followed by vomiting, rapid dehydration, muscular cramps, and suppression of urine. Unless there is rapid replacement of fluids and electrolytes, the fatality may be as high as 30 to 40%. Epidemiological features. Cholera is both an epidemic and endemic disease. The epidemicity and endemicity of the disease will depend upon characteristics of the agent and environment. Epidemiological determinants includes agent, host, and environment. Agent. Vibrio cholerae is gram-negative curved bacteria, positive for oxidase, grows in alkaline media, and it is a facultative anaerobe. The organism that causes cholera is labeled as Vibrio cholera 0 group 1 or Vibrio cholera 01. The term epidemic strain is used for these Vibrios. Within the 0 group 1, two biotypes, classical and EI tor, have been differentiated, but now mostly cholera is caused by EI tor biotype. Classical and EI tor Vibrios are further subdivided into three serological types, named Inaba, Ogawa, and Hikojima. Most of the EI tor biotype belongs to Ogawa serotype. Resistance. Vibrio cholerae killed within 30 minutes by heating at 56 degrees centigrade or within a few seconds by boiling. Remain in ice for 4 to 6 weeks or longer. Drying in sunshine will kill them in a few hours. They are easily destroyed by coal tar disinfectants such as cresol, and bleaching powder is another good disinfectant. Toxin production. Vibrios multiply in the lumen of small intestine and produce an exotoxin, enterotoxin. This toxin produces diarrhea through its effects on cyclic AIM system or mucosal cells of small intestine. Exotoxin has no effect on any other tissue. Infective dose. Cholera is dose related. Infection occurs when the number of Vibrios ingested exceeds the dose that is infective for the individual. Host, age and sex, all ages and both sexes. In endemic areas, attack rate is highest in children. Gastric acidity. It is an effective barrier. The Vibrios is destroyed in an acidity of pH 5 or lower. Conditions that reduce gastric acidity may influence individual susceptibility. Population mobility. Movement of population like pilgrimages, marriages, fairs, and festivals results in increased risk of exposure to infection. Economic status. Incidence is highest in lower socioeconomic groups and mainly it's due to poor hygiene. Immunity. Natural infection confers quite effective immunity and is mediated by local intestine immune system. Vaccination gives only temporary partial immunity for 3 to 6 months. Environment. Poor environmental sanitation. Environmental factors of importance include contaminated water and food. Flies may carry Vibrio cholerae but not vectors of proven importance. Social factors responsible for the endemicity of the cholera comprises of certain human habits favoring water and soil pollution, low standards of personal hygiene, lack of education, and poor quality of life. Chain of transmission. Reservoir. Human being is the only known reservoir of cholera infection, may be a case or carrier. Cases. Inapparent infection to severe. In cholera A at all, most infections are mild and asymptomatic. It is the mild and asymptomatic cases that play a significant role in maintaining endemic reservoir. Carriers, usually temporary, rarely chronic. They also make important contribution to the reservoir of infection. Since carriers exceed fewer vibrios than clinical cases, carriers are best detected by bacteriological examination. Carriers in cholera are of four types. Number one is preclinical or incubated carriers. Incubation period is of 1 to 5 days, so these carriers are potential patients. Then the convalescent carriers, patients who have recovered from cholera may continue to excrete vibrios during his convalescence for 2 to 3 weeks. Next is contact or healthy carrier, result of subclinical infection contracted through source of infection or infected environment. Last, chronic carriers occurs infrequently. Longest was found to be over 10 years. Gallbladder is infected in chronic carriers. Source. The immediate source of infection are the stools and vomit of cases and carriers. Large number of vibrios, 0 to 10 raised to power 9 vibrios per ml of fluid are present in the stools of cholera patient, and an average patient excretes 10 to 20 liters of fluid. Carriers excrete fewer vibrios than cases, 10 raised to power 2 to 10 raised to power 5 vibrios per gram of stool. Mode of transmission. Transmission occurs from man to man via fecally contaminated water, contaminated food and drinks. Associated with outbreaks of cholera, bottle feeding could be a risk factor for infants. Fruits and vegetables washed with contaminated water, cooked food contaminated with contaminated hands and flies. Direct contact, person to person transmission through contaminated hands of excreta and vomit of patient, and also contaminated linens and fomites. Incubation period from a few hours up to 5 days, but commonly 1 to 2 days. Period of communicability. Cases 7 to 10 days, convalescent carriers 2 to 3 weeks, and chronic carriers 10 years or more. Pathogenesis. In the large intestine, bacteria multiply rapidly. Bacteria release cholera toxin which penetrate into the intestinal wall. Then toxin prevents absorption of water by the intestine, leading to hypovolemic shock and dehydration. Clinical features. Severity of cholera is dependent on the rapidity and duration of fluid loss. However, a typical case of cholera shows three stages. Number one, stage of evacuation. Onset is abrupt with profuse, painless, watery diarrhea followed by vomiting. Patient may pass 40 stools in a day and stools have rice water appearance. Second stage of collapse. Patient soon passes to a stage of collapse due to dehydration. Classical signs are sunken eyes, hollow cheeks, scaphoid abdomen, subnormal temperature, absent pulse, unrecordable blood pressure, loss of skin elasticity, shallow and quick respiration, decreased urine output. Death may occur due to dehydration and acidosis resulting from diarrhea. Then the stage of recovery, if death does not occur, patient shows signs of clinical improvement, but if anuria persists, the patient may die of renal failure. Laboratory diagnosis. Diagnosis on clinical grounds can never be made. Laboratory methods are required to confirm. It includes the collection of stools, vomiters, water sample, food sample, then the transportation of these samples, then direct examination, culture methods, then characterization and biochemical tests. These are done for the confirmation of the diagnosis. Then comes the prevention of the cholera. First of all, the primary prevention, which includes the health promotion and specific protection. Health education, the most effective prophylactic measure, it should be directly mainly to the effective and simplicity of oral rehydration therapy, the benefits of early reporting for prompt treatment, food hygiene practices, hand washing after defecation and before eating, the benefits of cooked hot foods and safe water. Since cholera is mainly a disease of poor and ignorant, these groups should be tackled first. Specific protection includes the vaccine. Cholera vaccine consists of two doses given subcutaneously at the interval of 4 to 6 weeks. Boosters are recommended every 6 months. Not recommended for pregnant and persons with previous history of sensitivity reactions. Then comes the secondary prevention, which is the prevention by the spread of the rapid investigation of close contacts to ensure their proper treatment. Control and treatment of cholera. Best way to control cholera is to develop and implement a national program for the control of all diarrheal diseases because of similarities in epidemiology, pathophysiology, treatment, and control of cholera and other acute diarrheal diseases. The following account is based on the guidelines for cholera control recently proposed by WHO. First, the verification of the diagnosis, confirmation of the outbreak as quickly as possible, investigation of all cases of diarrhea for the specific diagnosis of cholera, identify Vibrio cholerae. It is important to identify Vibrio cholerae 01 in the stools of the patient. Notification. Cholera is notifiable disease locally, nationally, and internationally. Health workers should be trained to identify and notify cases immediately to the local health authorities. Early case findings, then the establishment of treatment centers necessary to establish easy accessible treatment facilities in the community. Then mildly dehydrated patients are over 90% of the cases should be treated at home with oral rehydration fluids. Severely dehydrated patients require IV fluids should be transferred to the nearest treatment centers or hospital. In areas where peripheral health services are poor, then mobile teams should be established at district level. Rehydration therapy. Cholera is now the most effective treated disease. Mortality rates have been brought down to less than 1% by effective rehydration therapy. The rehydration therapy may be oral or intravenous. Oral rehydration. Packets of oral rehydration mixture are freely available at all primary health centers. The contents of packets are dissolved in 1 liter of drinking water and consumed within 24 hours. If this packet WHO mix of salt is not available, then table salt 5 grams and sugar 20 grams dissolved in 1 liter of drinking water can be safely used. It is known as indigenous ORS or homemade ORS. Older children and adults are given water in addition to ORS according to dehydration level. Then comes the intravenous rehydration. It is usually required only for the initial rehydration, a severely dehydrated patient who are in shock and unable to drink water. The solution recommended by WHO for IV use are Ringer lactate solution, which is also called Hartmann solution, and diarrhea treatment solution DTS. Maintenance therapy. After the initial fluid and electrolyte deficit has been corrected, oral fluids should be used for maintenance therapy. The guidelines for maintenance therapy are given, and according to journal principle is that the oral fluid intake should equal the rate of containing stool loss, which should be measured. Diarrhea usually lasts for 1 to 2 days. Then the sanitation measures, chemoprophylaxis, and the tetracycline is the drug of choice. Then the vaccination and health education. As by the effective treatment, we can reduce the mortality rate and we can save 99% of the cases. Adjuncts of therapy. Antibiotics should be given as soon as vomiting stop, which is usually after 3 to 4 hours of oral rehydration. No other medication should be given like antidiarrheas, antiemetics, antispasmodics, or corticosteroids. If diarrhea persists after 48 hours of treatment, resistance to antibiotics should be suspected. Recent advances. In one of the article on the epidemiology of cholera, 7 pandemics of cholera have been recorded since the first pandemic in 1817, the last of which is ongoing. Overcrowding, poverty, insufficient water and sanitation facilities increases the risk for cholera outbreaks. The epidemiology of cholera in the areas in Asia, Africa, and America where the diseases occur continue to evolve. As you can see in the graph, this is from 1989 to 2017, and the blue color is for Africa, red is for Oceania, skin color is for America, and sky blue color is for Asia. There are many similarities in the spread, dynamics, and risk factors for cholera in the area around the world where the disease occur. But there are also important differences. In Asia, many parts of the India and Bangladesh are endemic for cholera and have seasonal recurrence of the disease. The global cholera picture continues to evolve and will likely change in the coming years, but it appears certain that in the times to come, cholera will continue to affect impoverished population without proper access to adequate water and sanitation. Then the European Center for Disease Prevention and Control, they have their overview, worldwide overview of cholera, and it was published in 2nd October 2020. And there's several countries in Africa, the America, and the Asia have reported cholera outbreaks. Major ongoing outbreaks are being reported from the Democratic Republic of Congo in Yemen. Haiti reported its last laboratory confirmed case in February 2019. Countries reporting the majority of new cases are Ethiopia and Somalia. According to WHO, between 5th September to 29 December 2019, 239 cases of cholera in Bangladesh. According to ECDC's assessment, cholera cases have continued to be reported in Africa and some areas of Asia. According to WHO, vaccination should be considered for travelers at high risk, such as emergency and relief workers who are likely to be directly exposed. Travelers to cholera endemic areas should seek advice from travel health clinics to assess their personal risk and apply precautionary sanitary and hygiene measures to prevent infection. These can include drinking bottled water or water treated with chlorine, carefully washing fruits and vegetables with bottled or chlorinated water before consumption, regularly washing hands with soap, eating thoroughly cooked food, and avoiding the consumption of raw seafood products. Then, according to WHO, cholera cases in Pakistan, it is the report of 25th October 2010, in which the confirmed cases of Vibrio cholera were 99 in Pakistan, and they were confirmed at National Institute of Health. These cases have been reported sporadically from the wide geographical area in the flood-affected provinces of Sindh, Punjab, and Khyber Pakhtunkhwa. And it is the last data available on the net from Pakistan. The total number, it is also of 2011. After that, there is no data available. The 527 cases of confirmed cholera cases were reported in Pakistan. Then there is interim guidance document of cholera surveillance by WHO. The objective of this guidance document is to support the public health professionals in implementing effective surveillance of cholera in at-risk, endemic, and epidemic areas. This document has been developed by the Surveillance Working Group of Global Task Force for Cholera Control at the World Health Organization based on these existing documents, guidelines, tools, and articles related to surveillance of cholera disease, as well as technical discussion with experts held during GTFCC meetings. For cholera, key factors for effective surveillance includes existence of a standard case definition, simple data collection tools, clear reporting procedures, analysis plan, rapid diagnosis of suspected cases and laboratory confirmation, routine feedback of surveillance data, and appropriate coordination at all levels of public health sectors like community, health facility, district, national, and international levels. One another document by WHO, cholera, the forgotten pandemic. Many people think of cholera as a 19th century disease. This is true for high-income countries, but elsewhere, cholera never went away. The current pandemic, the seventh, has been recorded, has been ongoing since 1961. It's the world's largest running pandemic. Cholera sickens approximately 2.9 million people every year and kills 95,000. The disease is endemic in more than 747 countries across the globe. In Africa alone, more than 40 million people live in cholera hotspots when outbreaks are a regular occurrence. You can see in the graph as well, in this picture. Then the cholera is preventable and manageable. There are new tools to prevent infections such as oral cholera vaccine and inexpensive efficient treatment that have been available for decades, in particular oral rehydration solution. But the health sector alone cannot prevent and control cholera outbreaks. The best way to prevent cholera and other waterborne disease is with the investment and maintenance of the community-wide water, sanitation and hygiene facilities. Peru, Vietnam, and Senegal are the examples of countries which have largely eliminated cholera outbreaks after investing in water and sanitation infrastructure and implementing targeted public health interventions. Ending cholera, a global roadmap to 2030. A global roadmap to 2030 is a new global strategy for cholera control at the country level, developed by health and development organizations, including WHO, through the Global Task Force Cholera Control. The goal is to reduce cholera deaths by 90% and to eliminate disease transmission in as many as 20 countries by 2030. The roadmap purpose that more effective control will be achieved through targeted and sustained preventive interventions in cholera hotspots, including the provision of clean water, adequate sanitation and hygiene facilities, and access to oral cholera vaccine. The roadmap was endorsed this year at the World Health Assembly as a part of global solution to address cholera. Then the role of the vaccine. Oral cholera vaccine are often used as an emergency medication in the event of severe outbreaks. This is complemented with improved sanitation, increase in awareness about cholera prevention. In recent years, the development of innovative approaches for cholera vaccine have fueled the growth of global cholera vaccine market. This is what Allied Market Research said in a recent report. The report says that global cholera vaccine market accounted for $65 million in 2017, and it is expected to jump to 207 million by 2025. One of the again article by the WHO researchers have estimated that every year there are roughly 1.3 to 4 million cases and 21,000 to 1,43,000 deaths worldwide due to cholera. And oral cholera vaccine currently present, WHO pre-qualified oral vaccines are Ducorol, Santrol, and Uvicol Plus. All three vaccines require 2 doses for full protection. Cholera kits. To ensure efficient and effective deployment of necessary material for the investigation and confirmation of cholera outbreaks as well as the treatment of cholera patients, WHO has developed a set of cholera kits. After consultation with implementation partners, WHO revised the cholera kits in 2016 to better meet field needs. In total, there are 6 kits, one for investigation, one with supplies for laboratory confirmation, 3 for treatment of the community, peripheral and central levels, one support kit with logistical materials such as solar lamps, fencing and water bladders and taps. Each treatment kit provides enough material to treat 100 patients. The revised cholera kits are designed to help prepare for a potential cholera outbreak and to support the first month of the initial response. These are my references. Now it's the turn for the multiple choice questions. Number 1. Vibrio cholera is active, non-motile, non-spore forming, capsulated, or gram positive. Non-spore forming. Strain of Vibrio cholera is stronger in water in David, Inaba, Agava, Ecuador, Eator, or Classic. B. Answer is B. Most powerful mode of transmission of cholera is flies, fingers, feces, or
D.
yes, D. Feces. Non-vibrant vector types is high mortality of D. Rotavirus, fruit fly, salmonella, shigella, and campylobacter. No, it's E. coli. B.
E.
WHO investigator for use in infection control of cholera is
Tetracycline.
tetracycline. During serious treatment of acute diarrheal disease, major concern is to replace sodium chloride, potassium bicarbonate, and
Potassium.
potassium. A solution contains 2 liters of water, 2.5 grams of sodium bicarbonate, 2.5 grams of sodium chloride, 1.5 grams of potassium. No, it's D, 1.5 grams of potassium chloride. Regarding cholera vaccine, the statement is that the highly effective vaccine is given in a dose divided into 0.5. It can,
D.
yes, it's D. Chemoprophylaxis injection of cholera is effective for pregnant females, children below 5 years.
D.
Is D, household contact. With effective antibiotic treatment, stool of infection contains Vibrio occurs 12 hours.
D.
What? No, it's D.
48
48
hours.
hours.
48 hours.
It's the key. Thank you so much.
It's a very good presentation. I would request all the participants please mute your mics so that I can comment on this presentation. Dr. Sati, it is a very good presentation, and as you have said, that many people believe that cholera has been eliminated from the world, but it is not so, and we are still having certain outbreaks of cholera here and there. And in Pakistan, we are having lot of cholera cases, and there are very many myths that are associated with it, and it is very important to bust those myths and give the correct information to the general public as well as to the specialists. As far as cholera epidemic is concerned, since the inception of Pakistan in 1947, we have faced an epidemic of cholera. At that time, the refugees were coming in, and there were refugee camps with the very little bit of uh, all sanitation and sewage systems and all those things. And there was the epidemic that caused major miseries and many deaths. However, at that time, the cholera vaccine that was being developed in India at that time was not available. So, King Edward Medical College developed the vaccine of cholera, and it was being offered to all those refugees during the epidemic. So, it is one of the historical role of King Edward Medical College and its graduate in controlling the cholera epidemic and spreading all those information about hygiene, hand sanitization, good practices of hand washing, cooking good food, etc., to the public. Here, I would ask Dr. Sadia, would you please elaborate more about the role of vaccine in prevention of cholera, especially about the live vaccines as well as other vaccines that are non-alive, that are killed vaccines?
Ma'am, usually the vaccine which is given in two doses is the killed vaccine, which is given. It's not given less than 1 year of age. It has two doses, 4 to 6 weeks apart. And in case if the first dose has never been given to a person, then if the only supposed to give one dose, then the dose quantity is increased because there are vibrios per microgram available in the vaccine. So the double dose, if one dose is required, then the double dose of the vaccine is given, and not given in the pregnant ladies and the patients with the immunocompromised can be given with this vaccine, but with the allergic reaction or sensitivity, those people cannot be given this vaccine. Um, its live version is also available, but actually I don't exactly know about that. I have read that there's the kill vaccine and there's live attenuated vaccine, but I don't know actually the details about the live vaccine.
Live vaccine, it has been approved by certain regulatory authorities, including FDA, and it is also approved by all the regulatory authorities that are like CDC, etc., who have recommended these vaccines. The live vaccine, it being prescribed for travelers to the area that are endemic or when there are the outbreaks have been reported several times. However, it is not routinely being advocated. It is against Vibrio cholera 01 strain. As we know that Vibrio cholera 01 strain, it is the most common type of the strain that is found in those areas that have the outbreaks. Another important thing that has to be noted is whether it is a live vaccine or it is a killed vaccine, there is no 100% effectiveness. So the most important thing about the effectiveness of the vaccine is that we have to promote the hand hygiene, good practices of cooking, as well as having good eating habits for better health that has to be promoted along with the vaccine. Another important point that I want to emphasize here, because it is also being heard all over Pakistan as well as internationally, that most of the women in Pakistan who are doing breastfeeding to their child while they are having any diarrhea or any symptoms of having watery stools, they usually stop giving them their milk. This is a wrong practice. So one of the myth buster that should be strongly recommended is that breastfeeding should be increased rather than decreasing. It should be increased. I would stop here. If you have any question, you may ask, please.
Thank you, ma'am.
Okay, thank you very much. Allah Hafiz. God bless you all.
Thank you, ma'am.